He was former professor and head of Department of Cardiology in GMC. He is the chairman of Hypertension Council, Asia Pacific Society of Cardiology. He is vice president of SARS Society, and he is national president of Cardiology Society of India. He has contributed many chapters in books, various books like API and Epicon updates, and various other books also. He did more than 30 books in the field of cardiology and get mega multi-specialty award during the Multicon 2008 organized by USA, and awarded WCCPC 2008 Lifetime Achievement Award by Dr. ABJ Abdul Kalam, and regularly organizing national symposia, seminar, and national conferences for last more than 30 years. Now I will welcome Dr. PC Manure sir to continue his talk about the hypertension, age, or ARB they are saying the connect here.
Yeah, sir, I'll be stopping this slide. You can upload your slide.
Sure.
Yeah, in the meantime, I request every doctor, if they have any query, they can post it in the chat box, or during the question answer session, they can unmute themselves and ask the questions. Thank you.
Good evening, everybody. Now, today we are going to give a talk on a very interesting topic. Are angiotensin receptor blockers equivalent to ACEI, that is angiotensin converting enzyme inhibitors, or they have divergent cardiovascular outcomes? Now, whenever we practice in cardiology, you must always be aware of these Chinese phrases, that is, superior doctors prevent the disease, mediocre doctors treat the disease before it is evident, and inferior doctors treat the full-blown disease. When we talk of the different subspecialties of cardiology, it is preventive cardiology which occupies a key place, because preventive cardiology decreases the burden of the disease. And all other subspecialty of cardiology, the cardiologist, whether he's a surgeon, whether he's a clinical cardiologist or an interventional cardiologist, must practice preventive cardiology, because that is the only way to decrease the burden of cardiovascular diseases which are reaching alarming and epidemic proportions. All of us know cardiovascular diseases have become the #1 cause of death in India and also throughout the globe. The crude death rate of cardiovascular disease increased by 34% from 1990 to 206. And the prevalence of cardiovascular disease has increased in India from 25.7 million in 1990 to 54.5 million in 2016. But the first step in preventive cardiology is you must be able to pick up patients like acute myocardial infarction and other cardiovascular diseases which are responsible for higher cardiovascular morbidity and mortality. And the simplest way to pick up who is at risk of acute myocardial infarction is given by the InterHeart study. This study, which is known throughout the globe, has shown that there are 9 modifiable risk factors which account for the major chunk of myocardial infarction, almost to the tune of 90%. And these, all of you are familiar with: hypertension, lipids, smoking, diabetes, abdominal obesity, alcohol, psychosocial factors, lack of physical exercise, and inadequate consumption of fruits and vegetables. Now, if both diabetes and hypertension coexist, the risk of cardiovascular disease increased by 5-fold. And hypertension is also rampant throughout the globe, even in our country. 1/3 of the adult population is suffering from hypertension, and distressingly enough, the control rates are hardly 10 to 20%. And this is the cardiovascular disease continuum. We have strategies for primary prevention. We have strategies for secondary prevention. Primary prevention is desirable. And dysregulation of RAAS is central to the pathogenesis of cardiovascular disease. And therefore, RAAS blockers is a logical approach to tackle this problem. And the issue today is whether it is ACEI which is better or ARBs are better or both are same. So let's look at some of the data. Now this is a horrifying data from large ARB trials, and this shows the prevalence of acute myocardial infarction in these trials. Look at this. The IDNT, which is done for renal disease, MI was seen in 54%. The CHARM HF trial, 52%. The value, 19%. The iPreserve, 11%. The scope, 10%. The life with losartan, 7%. And the on target, we'll see in detail, 7%. Which means that ARBs are not decreasing myocardial infarction. Many of them are increasing MI, some of them to a greater extent, some of to a lesser extent. But when we look at the data of AC inhibitors, you can see HOPE trial, all of you are familiar with the HOPE trial, a 20% decrease in MI, and Europa trial, all of you are familiar with the Europa trial with parenteral, a 22% decrease in MI. So this is the data on myocardial infarction in the context of angiotensin converting enzyme inhibitors and angiotensin receptor blockers. So obviously from this data, ARB increases MI, ACEI decreases MI. Now when we look at the AC inhibitors trial from the point of view of duration of the trial, what is very striking, as you can see on the screen from consensus to SAFE, as the duration of trial increases, the magnitude of benefit also increases. So longer is the duration of an ACEI trial, more is the increase. You can see consensus, there's less, and gradually when it progresses to SAFE, the benefit is more. Now this shows the comparison of angiotensin converting enzyme inhibitors and ARB on the cardiovascular events. The left side is an ARB. You can see ARB is producing a decrease in global death by 1%. Cardiovascular death is 1%, and stroke is -8%, and MI is +8%, which is MI are increased. But when we look at the ACE trials, there is universally reduction in the global death by 9%, cardiovascular death by 12%, stroke by 6%, and MI by 14%. So again, ARBs, they increase MI and produce some marginal benefit in stroke, whereas ACEI produces reduction in all the cardiovascular events. Now, all of you are familiar with the on-target trial, which tried to compare telmisartan with ramipril and a combination, and showed telmisartan is equivalent to ramipril. But when we look at the data, you can see the blood pressure readings in the ramipril arm was higher than the telmisartan. The systolic blood pressure clinic was 135 in telmisartan, 136.3 in the ramipril. The 24-hour systolic blood pressure was 124 in the telmisartan, whereas 127 in the ramipril group, and the daytime systolic blood pressure, again you can see telmisartan was 126 and ramipril was higher, 128, and so also the nighttime systolic blood pressure, 117 in telmisartan and 121 in the ramipril. So you can see that ramipril has higher blood pressure and telmisartan has lower blood pressure, but despite this, the MI rates was 7% more in the telmisartan group compared to the ramipril group. And this is the TRASCEND trial, which shows that ARB, which were used in ACE intolerant patients, failed to decrease cardiovascular events. Now, this is the famous roadmap trial, which was carried out with olmesartan, 4,000 patients, olmesartan 40 milligrams compared to placebo. The primary endpoint was new onset albuminuria and the follow-up was 3.2 years. Now you can see microalbuminuria was decreased by 27%, statistically significant, But look at the all-cause mortality. Hazard ratio is 1.70. Look at the cardiovascular death, it's 4.94, clearly indicating that olmesartan increased cardiovascular death in this trial. This is the BP-LTTC meta-analysis, which has compared AC inhibitors with ARB. Right on the top is AC inhibitor. If you see the effect of AC inhibitor on stroke, there's no change. If you look at ARB, there's no change, the green dots and the green square. But when you look at the coronary heart disease, AC inhibitor is decreasing CHD, whereas CHD is increased by ARBs. So it is for ACE inhibitors, but not for ARB. There's evidence of blood pressure independent effects of the risk of major coronary artery disease. Now, this is again a meta-analysis of AC inhibitor trials in CAD patients without heart failure or LV dysfunction. And again, you can see universal reduction in cardiovascular risk. All-cause death decreased by 14%, CV death 19%, MI 18%, stroke 23%, cardiac arrest 42%, myocardial revascularization 8%, and heart failure hospitalization 24%. So again, the data shows AC inhibitors are decreasing cardiovascular events. Now, these are meta-analyses of AC inhibitors and ARB. On the left side is AC inhibitors, on the right side is ARBs. And if you look at these meta-analyses, you will find that there is 9 to 11% reduction in all-cause mortality with AC inhibitors, 10 to 7% risk reduction in cardiovascular mortality with AC inhibitors, and 70 to 9% reduction in MI. Now, this is another meta-analysis in diabetic patients. Again, you can see all-cause mortality, AC inhibitor decreased by 13%, ARB to a lesser extent 6%, CV mortality decreased by 17%, and ARB, it increases CV mortality by 21%. CV events, AC inhibitor decreased by 14%, ARB 6%, and MI, AC inhibitors in this meta-analysis decreased it by 21%, ARB only by 11%, heart failure decreased by 19%, and ARB 30%. Stroke, AC inhibitors decreased by 5%, no change with ARBs. Now, this is another data of, you can see 2,54,000 patients comparing AC inhibitors with ARBs. And you can see all-cause mortality is decreased by 11% with AC inhibitors, but not by ARBs. Cardiovascular mortality decreased by 17%, not with ARBs. And MI is decreased again 17% by AC inhibitors and 7% by ARBs. Now, this is another comparison of AC inhibitors and ARB, and you can see if your patient is suffering from hypertension and you are using AC inhibitors and ARBs, you can see AC inhibitor use is associated with reduction in mortality right on the top. If your patient is diabetic, AC inhibitors is associated with reduction in mortality, ARBs are associated with increase in mortality. If you're suffering from CAD, AC inhibitors are associated with decrease in mortality, ARB is associated with increase in mortality. And if you're a high-risk patient, again, ACE inhibitors decreases mortality, whereas ARB, there's trend towards increase in mortality. Now, when Normal Kaplan was asked about this, do ARBs increase the risk of MI? The answer is almost certainly favored ACE inhibitors. And this is the Cochrane review. Cochrane is a non-profit, non-governmental organization which is formed to organize the medical research findings so as to facilitate evidence-based choices about health intervention faced by health professional, patient, and policy. And what is the viewpoint of the Cochrane review? The Cochrane review also shows that there is weaker evidence for the efficacy of ARBs in terms of mortality and morbidity outcome compared to AC inhibitors. And in summary, while ARBs are slightly better tolerated than the AC inhibitors, There's higher quality of data supporting the use of ACE inhibitors to prevent death, strokes, heart disease, and they should be considered first. Now, the only problem with ACE inhibitors is that they can produce coughs. So ARBs have a 1.8% lower chance of being stopped due to side effects over 4.1 years, meaning that for every 55 people treated with an ARB instead of an ACE inhibitor for 4.1 year, one person would be spared from a side effect leading to stoppage of the drug. This difference in side effects is mainly due to higher rate of dry cough in people taking ACE inhibitors. And therefore, when you are selecting drugs, you should keep in mind that ACE inhibitors are more effective than ARB. The only problem is cough, which is seen in small percentage of these patients. The next question arises as to, is there a difference in the pathophysiology, the mechanism of action between ACE inhibitors and ARB, or both are same because both are RAAS blockers? Now, all of us know this is the renin-angiotensin-aldosterone pathway. Angiotensinogen is converted into angiotensin 1 by renin. Angiotensin 1 is converted to angiotensin 2 by ACE enzyme. And angiotensin can also be directly converted to angiotensin 2 through the non-ACE pathways. And this is a negative feedback loop, as you can see. Now, another thing you must also remember is that the ACE not only acts in the circulating blood, they also act at the level of tissues. And while selecting an angiotensin converting enzyme inhibitor, you should try to select an agent which also has a good effect on the tissue ACE. Circulating ACE, as you can see, they produce vasoconstriction, negative feedback on the renin secretion, they stimulate aldosterone secretion. But the function of tissue ACEs, which is mediated through bradykinin, they offer a panoply of protective effects, as you can see on the blue circle in the slide. So if ACE inhibitors are used, it increases plasma renin activity and angiotensin 1, and through compensatory mechanism, but do not increase angiotensin 2 levels. But if you use an ARB, it increases angiotensin 1, it increases angiotensin 2 because angiotensin is not able to act on the AT1 receptors, and also increases plasma renin levels. Now, once you give an ARB, because the angiotensin 2 is not able to bind to AT1 receptors, its level goes on increasing, and it tries to stimulate the other AT receptor, the AT2, the AT3, the AT4. And if the AT2 receptors are stimulated, now we have evidence and it can produce adverse effects in terms of hypertrophy, remodeling, plaque stabilization, inflammation. And there's also some data coming from stimulation of AT3 receptors that there may be endothelial dysfunction and it may generate a prothrombotic strategy.
Recent data suggests that stimulation of AT2 may even be harmful under certain circumstances through mediation of growth promotion, fibrosis, and hypertrophy, as well as pro-atherogenic and pro-inflammatory effects. The excess circulating angiotensin 2, by acting on AT2 receptors, augments matrix metalloproteinases 1 enzyme levels beneath the plaque, and increased levels of MMP1 enzyme has been implicated in causing plaque rupture. Thus, the long-term consequences of ARB therapy might be less beneficial. And this shows the effect of ACE on MMP1. You can see ACC decreases, ACEI decreases MMP1, and the greatest reduction is seen with ramipril. This shows the differential effects of ACE inhibitor and ARB on PI1. PI1, as we know, is a major inhibitor of fibrinolysis, and increased levels are prothrombotic. PI1 is a critical determinant of plaque stability and rupture, and PI1 also is the strongest independent predictor of death following STEMI. And here you can see that ACE inhibitors decreases PI1 level to a greater extent than ARB. Now, whenever there is endothelial dysfunction, There is increase in the local mediators. The pi1 level increases, which produces thrombosis. The cytokines ICAM and VICAM increases, which produces inflammation. The endothelin level increases, which produces vasoconstriction. Likewise, in the plaque, there is increased ACE, which decreases bradykinin levels and decreases nitric oxide level, which produces vasoconstriction. There's also vascular remodeling, and increased proteolysis produces plaque rupture. If AC inhibitors are used like Remipryl 10 milligram, the local mediators are decreased, the plaque ACE is decreased, and all these produces protective effects and reduction in the clinical events. So this shows that AC inhibitors produce benefit by a dual mechanism. The angiotensin 2 levels are decreased, which produces panoply of beneficial effects, as you can see on the slide, and there's increase in bradykinin levels, which also produces several beneficial effects. So the take-home message is clinical evidence suggests that ACEI and ARB have divergent CV effects on CV mortality and MI in high-risk patients. AC inhibitors reduce the risk of MI and mortality in high-risk hypertensive patients, as well as in diabetics, the elderly, those with vascular disease, and in congestive heart failure. ARB, in contrast, have not shown to reduce the risk of MI or death in clinical trials. And systemic reviews further confirm that ARB lack the cardiovascular protective effects of ACEI, and all these has been documented in literature. As you can see, the divergence cardiovascular effects of angiotensin converting enzyme inhibitors and ARB on myocardial infarction and death. And the second publication, the divergent cardiovascular effects of ACEI and angiotensin 2 receptor blockers in adult patients with type 2 metal. We are amidst the COVID era, and unless we talk about COVID, the talk will not be complete. Now, in COVID era, the current recommendation is that if the patient is on ACEI or ARB, it should be continued and it should not be stopped, and all global guidelines have endorsed this view. In the COVID era, if you want to protect yourself from COVID, you have to avoid man and follow woman. Avoid man means M stands for mouth, E for eyes, and N for nose. So you have to avoid touching these parts. And woman, W stands for wash your hands, O, obey physical distancing, M, mask compulsory, E, eat right and exercise, and N, no unnecessary tools. So in the COVID era, if you want to protect yourself from COVID, avoid man and follow woman. Thank you very much.
Hello?
Yes.
Hello?
Yes, yes.
I want to know whether valsartan also does not, valsartan increases MI or any cardiovascular deaths. Valsartan.
Valsartan has been tried in heart failure. There is a VALF trial. It does not decrease MI. ARBs, they may increase MI or they may have a neutral effect, but AC inhibitors decrease MI.
Okay.
Dear doctors, if you have any questions, you can put it in the chat box. I'll read it for you, or you can unmute yourself and ask the questions.
Dr. Manoria, there is a question here which is asking, does number needed to treat play an important role in your choice of treatment? If yes,
certainly it plays an important role.
Thank
the
you,
number
sir.
needed to treat is in AC inhibitors is much less compared to the other agent.
Right, sir. Thank you. And sir, what is your view on central aortic pressure? There is this new concept which is evolving that central aortic pressure is a better marker compared to brachial BP.
Yes.
And possibility of ACE inhibitor plus calcium channel blocker as a key agent in reducing central aortic pressure compared to brachial BP. Sir, your thoughts on this?
Yes, certainly central aortic pressure is a better predictor of cardiovascular events as was shown by the CAPI trial, the subgroup study of the Escort trial. And there is also differential effect of the antihypertensive agent on the central aortic pressure. For example, the amlodipine decreases central aortic pressure, the AC inhibitors decreases central aortic pressures, beta blockers like atenolol increases central aortic pressure, nebivolol decreases, and diuretics, they don't have any significant effect. Central aortic pressure is now going to come in your clinics after 10 or 15 years. It has been validated. You can measure it non-invasively, just as ambulatory blood pressure previously was a research tool, but it has now come in many of our clinics. So also it is expected that central aortic pressure is likely to come in the clinics maybe after 5, 10 or 15 years, because we have a now value. The other thing with central aortic pressure is used in high-risk patients. It is seen that if you have an elevation of central aortic pressure, then there are chances that this individual is likely to develop hypertension in future. It is also being tried by the epidemiologists to pick up those individuals who are more likely to develop hypertension in future.
Ramipril and enalapril, how do you compare?
The best data is with two ACEI inhibitors, ramipril and perindopril. The best data for heart failure is with enalapril. For preventive cardiology, the best data is with perindopril and ramipril. Both these have been tried in the HOPE trial, the Europa trial, and several others. For heart failure, the best data is with enalapril. That's why enalapril was compared with ARNI in the paradigm method trial.
Thank you.
All ACEI inhibitors improve.
So now we should start.
Hello?
We should start using AC inhibitors now instead of losartan or telmisartan or olmesartan.
Yes, if there's no problem of tolerance, you can start. But for CKD, both are equivalent. CKD, we do not differentiate between ACE inhibitor or ARBs. There are more data on type 1 diabetes with ACE inhibitors and more data of ARB with type 2 diabetes. All agents, ARB and ACE, have not been tested in type 1 and type 2.
So one question which usually doctors in tertiary care institutes, they ask if a patient is already on an ARB when he is brought in or wheeled into the hospital with a MI, if he is already on an ARB, should one change this treatment from ARB to ACE inhibitors?
Immediately, you should not change. Whatever the patient is on, you should continue.
Sir, how can we control the cough with the AC inhibitors?
See, cough occurs in 5 to 30 or 35% of patients. The figure keeps on varying. Cough is due to increased levels of bradykinin, and the best treatment is to stop AC inhibitor. But for making a diagnosis of AC-induced cough, you stop AC inhibitors, again reinitiate, cough occurs again. This is a true AC-induced cough. Anybody developing cough on an AC inhibitor does not. It may be due to left ventricle failure, due to chest infection. The diagnosis made, you stop the drug, cough disappears after some time, reinitiate again. That is diagnostic of ACEI cough.
Sir, this is the now recommendation that the COVID patient, if taking the AC or ARB, they should continue. But on the other hand, ARB increases the sensitivity of AC2 inhibitor from the where COVID enter in the body.
See, this was a theoretical presumption, but now we have data that even ACE inhibitors produces better data compared to ARBs. But they should not be stopped, they should be continued.
But from the reports from the Chinese paper, they are saying the older patient, those are taking AC inhibitor or ARB, having the COVID with the pneumonia, they died more in comparison to other patients taking the antihypertensive drugs.
That was the initial impression. Now all guidelines globally has recommended they should be continued, and we have a data that ACEI produces better protection than ARB. That was initial impression. This is no longer true. This is a myth now.
Hello.
Yes.
Would you prefer losartan or ramipril in stroke?
In stroke, ARB has also shown good results. You can also use losartan, no doubt.
Okay, thank you.
Dear doctors, if you have any query, you can put it in the chat box, or you
So,
can.
Madam Asha Murthy, Madam has raised a hand. Madam, what would you like to give your comments? Dr. Asha Murthy, Madam from Chennai, has joined us.
Yes.
Madam, anything you would like to speak, or maybe any questions or any comments from your end?
And another announcement I'd like to make is those who are interested in the recorded version of this webinar, they can send a WhatsApp to me. The link will be sent. My number is 989-30-42229. 989-30-42229. The link will be sent to you.
Over to you, sir. Avdesh, sir.
Okay, thank you, sir. It is very excellent track, and now it is very clear by your talk that it should be preferred in primary, even in secondary prevention. And now everything is clear. If there is no more question, we can close the session. Thank you very much, sir, and thank you to the organizer.
Yeah, sir, we do have our RBM, Mr. Srijit Srinivasan, so he'd be saying a vote of thanks for this. Over to you, sir.
Good evening, everybody. I'm Srijit, and I'm the regional manager based out of Mumbai. So, on behalf of Sanofi, I would like to thank all the doctors, especially during this time. You are at the forefront fighting the COVID disease during these extraordinary circumstances. And a big salute to each one of you at this point of time. Today's session was an excellent session by Dr. PC Manoria sir, and well chaired by Dr. Avdesh sir. So in fact, follow women and no men was one of the key take-home messages of this session as well. Apart from the ACE versus ARB, which one is much better in terms of CV protection. So thank you, Dr. Manoria, for giving so much of insights into this topic. I would like to thank all the doctors who have taken out your valuable time and attended this session and attended with a lot of questions coming from your end. I would like to thank my colleagues, the medical representatives of MP, who have taken out their efforts to invite everybody and to make this event much more successful. So, sir and everybody, Sanofi is always at the forefront to conduct more such academic events, and in the future also we will be conducting more such events. So, thank you very much for attending today. Have a great day. Good day.
Thanks a lot, sir. Thanks for your valuable presence. Have a nice day.